So I'm giving a very short introduction of Dr. Mary. She has been an assistant professor of medicine at in the division of geriatric and palliative medicine at the Medical College of Wisconsin from 2014 until just few days back, and now she will be beginning a new role in Loa City this summer. So all the very best to Dr. Mary for her new role. And our co-facilitator for the session is Dr. Biju Raghavan. He's a senior consultant and HOD in pain and palliative medicine at the Rajgiri Hospital in Ernakulam, Kerala. He has done his PG diploma in pain and palliative medicine, and he's also visiting faculty at the Trivandrum Institute of Palliative Sciences in Trivandrum. So, welcome to both of you, and over to you, Dr. Mary.
Dr. Mary, you are muted. Yeah.
Yep. All right. Thank you. Thank you so much for involving me in this. So we are going to approach this session a little bit differently than the prior sessions, especially in the way that we approach the case presentation. Also, Dr. Biju and I will sort of trade back and forth who's speaking about what. He'll be focused a lot on kind of giving some background information on different topics, and then I'll focus on a framework for communication. So it's been a pleasure to get to work with him. So we are talking about communication and end-of-life counseling. Please let me know if you have any problems seeing my screen appropriately. Objectives for today are to describe for you to be able to describe a communication approach for making recommendations toward comfort-based care at end of life. Particularly in times of kind of transitioning goals. Name 5 approaches to addressing anger and other strong emotions during end-of-life decision-making, and then being able to apply these approaches to discussion of feeding for comfort rather than force feeding or tube feeding at end of life, and describe using this approach to counsel patients and family against ICU interventions at end of life. So actually for part 1, I'm going to hand off to Dr. Biju.
Thank you, Mary. And it's been a pleasure working with you. And welcome to all the delegates who have joined from from all over for this program. And as Dr. Mary said, we'll be just doing it back and forth. My approach to this would be how I would actually be counseling a family member regarding these issues of force feeding, and in the second part on protecting patients from futile aggressive interventions. And Dr. Mary will thereafter put it in the context. So let us start. Who has this slide with them? Oh, you have. All right. Okay. Right. Right. So generally what I do when I have to counsel a family member, I would make them sit with me, and I'll take a piece of paper and a pen or a pencil. And then the first thing I'll do is I'll start by drawing a tree. Next slide. Yeah. So I tell them, see, and the context is where the family is complaining that the patient is not eating enough. And why is that? Because the patient is terminally ill and is in the stage of anorexic syndrome, which is characterized by progressive loss of appetite, progressive loss of weight, progressive loss of strength. And in this context, the family members get very anxious and they try to force feed the patient. And this is the context in which I am counseling the family member. I take a piece of paper and a pen and I draw a tree. And I tell them, a tree needs energy, and the energy, am I not audible properly?
Sir, you are very audible for us, sir.
You are, I am audible? Okay.
Yes, yes, yes.
Yes.
So may I proceed?
Yes, you can.
All right. So as I said, I take out a piece of paper and draw a tree, and I tell them a tree needs energy, and it gets from the sun above and from the earth below. What would happen? Next slide. What would happen if this tree were to be infected by a parasite which can't be cured? Initially, nothing much may happen, but as the parasite spreads, next slide, the tree would, next, 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 yeah, the tree would eventually dry off. Now, this cannot be the tree's fault if the parasite is progressed, has taken control of the tree, and the tree has shriveled and dried. Now, this happens despite energy, the sun and the earth still being there. That means even if we were to provide additional nutrition to this tree, let us say we put a lot of truckload of fertilizers at the bottom of the tree, it will not become green again. And I would ask them, why do you think this is happening? Most of the time, the family members will say the parasite is taking away the energy meant for the tree. And I tell them, yes, you are right, but there is another factor in play. And what that factor is that the parasite is creating an irreversible chemical change inside the body of the tree, because of which, even if energy is available, the body of the tree cannot use it. So it is a double whammy. On one side, there is loss of energy because the parasite is taking it away. On the other side, even if energy is provided, the tree is unable to use it. Next slide. And this brings us to the question, would force feeding be beneficial? So in this condition, if the body is taken over by a disease, which is in fair advanced condition, and the body is shriveled and dry, the person does not want to eat. In this kind of situation, what do you think? Would feeding improve the health of the person? And most of the time, by this time, the family would come to understanding, no, it will not benefit the patient. Next slide. So this is where I kind of clarify what this phenomena is, anorexia cachexa syndrome. And in a patient being in that situation is not the patient's fault. It is just how the disease is treating the body. And if our expectation of force feeding is that the person will get better, that is not going to happen. So we will have to bring down our expectations. The futile expectation is not going to happen. Then the question comes, is there any harm in force feeding the patient? So that is something to be thought about. Then I tell them, imagine you just had tummy, you just had, yeah, please, next slide, just the heading only. Imagine you just had a sumptuous meal, and then somebody who's very important in your life comes along and says, hey, I am hungry, let us go for lunch. What would you do? You would most probably say, I had my lunch, I will come and sit with you. But that person says, no, 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 you have to have lunch with me. And the person forces you to have one meal on top of the meal that you just had. What possible discomfort are you likely to have? Next slide. Probably you will have tummy ache or abdominal discomfort. Next slide. Or you may find it difficult to breathe. Next slide. Or you may have nausea and vomiting. You may find it difficult to sleep. So that means if you take more than what your body can tolerate, you will suffer physically. And this is exactly what happens to the patient also. So according to you, the patient is not eating much, but from the patient's point of view, he's not able to tolerate the quantity of food that you want to force him to eat. And as a result, they suffer physically. Then I asked them, what if this person who force fed you, made you have a double meal lunch, continues to torture you like this every day? Would you be happy to see him? Would you be courteous with him? And most of the time, the family members say, no, I will be angry. Then I tell them, yes, and that will be very reasonable, because in this kind of situation, people, family members realize that the patients are getting angry with them. And not only angry, when people force things on somebody, they feel isolated. Next slide. And they feel helpless. They feel lonely. And nobody essentially takes their side. Everybody takes the side of the family, the friends, relatives, even the medical professions tell the patient, you must eat, you must eat. I'm prescribing you protein powder, I'm giving you this stuff, I'm giving you that stuff, you must eat. And as a result, the person has a lonely battle at hand. Many a time, such enormous emotional torture breaks the will of the patient to even live. They just wish I were dead. Apart from the physical and mental torture we subject the patient to, there is also the question of the relationship suffering as a result of that. Because sometimes the patient may say some harsh words to the family, and in a fit of emotion, the family members may also say something harsh, and this breaks down the relationship. There is such a pressure cooker atmosphere in the house with so much negativity that it is just a matter of time before the whole household implodes. So relationship suffers apart from physical torture and mental torture. And none of this is being done by the disease. This is because of how we are treating the person with the disease. Next, there's a question of dignity of life. There are two ways we can uh, cause a damage to the dignity of life. One, forcing people to do things that they don't want to. For example, if I don't want to eat, you force me to, then you are assaulting the dignity of my life. Similarly, if I want something, can we go back, please? Something, if I want something and you deny it to me, then also you are assaulting the dignity of my life. For example, I've seen plenty of situations where a patient in the end stages of life would like to have a smoke or would like to have a drink of alcohol or something like that, or a diabetic may want to have something sweet. Many times the family members deny them. I'm not advocating smoking or drinking. I mean, we should make sure that the new generation studying in schools are taught not to drink and smoke. But there's no point lecturing a person on their deathbed not to drink and smoke. Probably that's the only thing that gives them some happiness in their life. But many a times we see those things are denied. So the question is, we have to designate the patient as the captain of the team, and we all play under his or her rule. We agree with whatever the patient wants, and we will not force anything that the patient does not want. Another problem with force feeding is, next slide, please. Many a times it leads to aspiration pneumonia, and we all know aspiration pneumonia kills. And this major contribution of force feeding is aspiration pneumonia. And not only it causes a person to die with a lot of suffering, it also means that they die much before than they would have. That means force feeding leads to not only decreased quality of life, it also leads to decreased quantity of life. The same thing can happen if we give excessive IV fluids and lead to pulmonary edema and death. Uh, and TPN can cause septicemia in this kind of situation. So in a terminal inpatient, it is best to do less, because doing less is doing more in this kind of situation. So we can avoid a lot of medical harm. Next slide, please. So the dilemma is that we have to advocate for the patient, and most of the time we may have to fight for the patient, keeping the family, the relatives, and society at the other side. But it is not something that you fight in a negative way. You have make them sit down. You take a piece of paper, you take a pen, draw a tree, and tell them why it is not going to help. You tell them why it is harmful. And most of the time, my experience is people turn around. They come to understand, they come to accept. And that is the only way we can protect our patients from harm, which comes about because of the love and affection that the family has towards it, and they don't know how to channelize it. Most of the time they channelize it by forcing food, and Dr. Mary will be talking more about it, so I will not go much into it. Next slide, please. So basically, this is something that we will remember when we go to the next part, not now, but I'll just talk about this anyway. As our age increases, as shown in the blue line, or if we have incurable progressive disease, our health declines as seen in the green line. And this is on the this is as the time increases, our age increases and health decreases. Next slide. So, and if we have if we just think about ourselves, when we were teenagers, 15, 16, we used to have enormous appetite. But now, as we are growing old, now I am in my past mid ages, and my appetite is down. I can't eat as much as I used to. Can we just hold it there? And because of this, the quantity of food I'm taking now is almost 50% of what I could eat as a teenager. If I were to eat like a teenager now, I'm really going to suffer. So it is not my fault that I grew old. And if I were to get an incurable progressive disease, I will not be able to eat as much as I am able to do even now. So as these things progresses, our health declines, our body's requirement comes down. And as a result, if the body does not need the energy, appetite goes away, and gradually the quantity of food comes down till a point where the body does not want food anymore. And as we progress along the timeline, the body's requirement of water, next, water comes down and thirst goes away. And gradually there comes a time when you are completely happy not drinking even a drop of water. At this point of time, forcing water into the body will only cause suffering. And next, there comes a time in the fairly end stages when the body's requirement of air comes down, and then the desire to breathe goes away. A point that comes where I don't want to breathe again. And that point of time, you would say, Dr. Biju Raghavan has died. Next. And the reason why Dr. Biju Raghavan died is because Dr. Biju Raghavan was born some time ago. The only reason we die is because we were born. So there is nothing unnatural about it. And at this point of time, if you push me into the ICU and subject me to all kinds of critical care, you can't save me, you can only torture me. We will talk about this in detail later on. Next slide. So we talked about what not to do. Let's talk about what we should do. As Dr. Mary said, we are advocating comfort feeding and protecting the patient from force feeding. What is comfort feeding? That means no dietary restriction. Patient can have whatever they want, whenever they want, in whatever quantity they want. That means leave it to the patient. And the patient says, I don't want anything. Help the patient not to have anything. So focus is on comfort, feeding, and protecting the patient from force feeding. Next slide. Right. So I am handing over the baton to Dr. Mary. Dr. Mary, can you take it from there?
Thank you. So Dr. Biju gave really valuable ways that he approaches these discussions, and realizing that a lot of us need to also kind of think through different type of wording that might register for us. We wanted to kind of give you a framework for how you might approach discussions. One framework I find valuable is the REMAP method, which is something we sent out to you all in an article. I'm not sure if it's something that's familiar to people or not. It's kind of largely intended as a framework to be used when you're kind of transitioning medical status and associated goals. It's a framework that's intended to allow a really valuable discussion and without making a prolonged discussion necessarily if you have limited time. So it's meant to be something that can be more time consuming or can be done relatively quickly. And one thing I wanted to share with you all, so Vital Talk is an organization in the United States that does a ton of communications training. And I did want to provide this website because within their Vital Talk website, they have accessible free resources that cover REMAP, cover a bunch of other different approaches to serious illness communication. There are videos. There are even some COVID specific resources. So if anybody would like to access it, please do. And Vital Talk, full disclosure, I'm not directly Vital Talk trained. I was trained by somebody who was Vital Talk trained earlier in their process, but it's kind of all revolving around 3 core principles. One being that response to emotion is often more important than the amount of actual information relayed. The idea being that if we don't allow people to process their emotions and to kind of be in a space where they're ready to hear information, what we're saying may not have the real value we hope it will. 2, information should be relayed in discrete, understandable segments, and treatment plans should center on patient values. And so when used effectively, this approach will hopefully allow conversations to build on each other because you've had discussions about values. Okay, and every communication approach I'm going to advocate will always be kind of structured on this idea of asking the patient about their understanding of a situation or about their values, telling them the information you find is appropriate, and then trying to ask toward the end about their understanding or the emotions surrounding that information. And this approach can really be used with pretty much any end of life treatment decision. With any discussion about end of life, I always start with a question. Most often that question is something like, what have you been hearing? And the REMAP method says that from there, after we hear what people have been already understanding, we reframe the information. We expect emotion and empathize. We map out their goals, the patient or the family's goals. We align with their values, and then we plan treatments that match that patient, that family, those values and goals. And so we'll use as an example to teach REMAP this case of anorexia cachexia syndrome and surrounding expectations. So it's not uncommon that I might meet a patient and a family member, and the family member says, he's losing weight. I'm concerned he hasn't been eating as much as he should. He just isn't trying hard enough. And so the approach that I would tend to take is to reframe this concern, right? You want to use language that's aligning, that's not pushing people away, and language that allows the uncertainty that really exists, that doesn't make it sound like you know for sure, because often there is uncertainty, but also makes it clear that you're concerned what they're saying is not quite where we're really at. So reframing techniques I like to use are simple words like, I'm worried, or I wish that. Both of these options are very aligning, and they're also very clear that we may not be where they're hoping we are. So an example specific to the statement made in the prior slide might be, I wish there were a good way to help him gain weight. I worry his weight loss is a sign of his cancer worsening, and I don't suspect we'll be able to reverse this. Depending on the response, you may also add, I worry if we force him to eat more, we may actually cause harm. And then you pause and you expect emotion. I think there was a lot of interest in this topic and making sure we addressed how do we respond to strong emotions like anger, because it can be really challenging to not escalate situations. It's common, right, when we reframe something about end of life, that people feel a lot of emotion. It might be sadness, it might be outrage, could be anything. It could be desperation. So we hear it. And ways that we might approach, I'm not sure if people are already familiar with this idea of the nurse statements for mnemonics. where the N is for naming, where we actually name an emotion that we see. Usually if it's a very strong emotion, I might recommend toning it down a bit. Oftentimes people don't like to be told they're angry when they're angry. You might use a bit softer word like frustrated. So naming an emotion might be, I can see this is very frustrating to you. U is for understanding. So a statement that expresses your understanding kind of generally where they're at. Or often I flip it a bit and instead note that I can't really understand, right? There's no way for me to fully understand what you are going through with your loved one right now. So I might say, I can't imagine what you're feeling right now. R is for respecting. A statement respecting the role that this patient has played or that this family member has played in their loved one's care. You have been such an important support for him doing as well as he has for so long. S is a supporting statement, something to show that you won't be abandoning them, right? A statement to say, even though things are different, I'm here. So we are going to keep caring for him. And E is an exploratory statement. Something simple like, tell me more about your concerns. When I use these different statements, I think it's important we name that it's not just throwing out the statement, but it's making the statement and then waiting for more, right? Waiting to see where people are at. With food concerns, sometimes the emotions can be really strong, right? Food relationships are very intense. And I think this crosses cultures, right? That for most of us, food is the way that we share with our families. It's the way that we show each other love. And so sometimes I'll specifically name that, right? A respecting statement might be, sounds like you've been working very hard to help him gain weight, right? A naming statement might be, it sounds like concern about food has caused conflict between you. Sometimes I'll get more specific to this food relationship. Sometimes I'll say something like, I can only imagine how hard this is, right? Sharing food is how we show each other love, right? And I actually find that, at least in my context, that seems to resonate with people and allow them to understand that I can appreciate this. And then it's only after people have been able to kind of move through some of these emotions that we can really go on to the next part of discussion. Usually this doesn't actually take all that long. Usually once we really address the emotion, it allows people to pass through them. And then the next step, once we've responded to this emotion and this reaction, is to map out goals. And not our goals, but the patient or the family member's goals. So we ask them exploratory questions, right? Given what I've shared, what are you most hoping for? And letting them outline it, right? Or the other side of that, what's the scariest thing about watching this change? And really pausing and letting them talk. And the A is for aligning with values, right? And so this is just usually a very simple statement, just a way of saying, I hear you, right? Allowing them to know that you're there and really listening. And also a way for you to cross-check that you've really heard them correctly. So an aligning statement might be, it sounds like you'd like for him to eat more and you'd like for food to not be a constant argument between you. Or it sounds like your top priority is ensuring he's cared for and comfortable. Making sure that they're really kind of approving whatever statement of understanding you made. And then the P is for plan for future treatments. And so the recommendation here would be to make sure that we take what's been said and their goals and their values and provide a real recommendation around that. I think, at least in the context where I practice, a lot of times we kind of toss out two options to patients or families and put them out as if they're both equal. But really it's our role to make the recommendation specific to that patient. So a lot of times I might use the words, given what we've discussed. And then I'd recommend that we call what we call comfort feeding, right? This allows him to guide what he eats and when. I think this will allow him to be more comfortable and will hopefully decrease the pressure you feel to try to make his body gain weight. Oops. And so this is that idea with comfort feeding, just like Dr. Bijou outlined, right? Where someone can eat whatever they want, whenever they want, in whatever quantity they want, or as little as they want. And kind of as families asking questions, then we can be really outlining what does this look like? And importantly, emphasizing that the family can offer food while we need to kind of be accepting that the patient may or may not actually be comfortable eating it, and it's completely normal, right? And not a fault of the family, and offering that reassurance. So this was just a summary of those remap steps: the reframe, expect emotion, map goals, align with values, and plan treatments that match the patient. And so I think now we wanted to kind of open it up for discussion, hearing from people what might resonate from them or challenges they might have with these different aspects. So we welcome questions.
Dr. Mary, we have a question in the chat box here by Dr. Sachidharan. So he's actually wondering about how to communicate regarding invasive procedures like esophageal dilatation or stenting in a inoperable metastatic case of CA esophagus. So how do you go about it? Would
Yeah.
you like, the question he's asking is what is your suggestion regarding this? Should we ask the patients, or what is your opinion? Should we go for these procedures, invasive ones, or not?
Yeah, so I think, and I'll be interested in Dr. Biju's take on this too. I think when we're talking about invasive procedures like that, a lot of times for me, it will be talking with the oncologist, talking with maybe the GI specialist who might do the procedure about where the patient's really at, right? And how long do we think time might be? Will time be long enough to benefit from that procedure? If we think that a patient might have some real time, and some real time that might be very quality time. And if they would like to eat by mouth and there's an obstruction keeping it from the food from getting to their stomach, in some circumstances, I would recommend stenting, right? If it might allow somebody to enjoy food, it might allow them a prolonged life, and if they don't mind a procedure. And those would be the types of information I would try to get when I was asking about goals, right? If they're saying, I really want to be able to taste food again and not have it just be stuck, then I think it may be a very reasonable option, right? If we're addressing hunger by allowing food to actually pass, then it's a very reasonable option. I don't know what Dr. Biju might say.
I agree with Dr. Mary. The only thing that I think I need to add is I would want to know by the opinion of the treating doctor regarding the intervention that they plan. What is the outcome they're expecting out of the intervention? Have they thought that through? If they see a merit in that intervention, uh, we discuss this case by case on the merit of the patient's condition. If they feel that there is merit in that intervention, and then we go to the patient and the family to find out where they are at. Are what are their goals? What are their concerns? And it is basically many a times as a palliative care physician, I end up doing a bit of liaising work between the treating doctor, the patient, and the family. Three entities liaising, because sometimes the patient goals and the family members' goals may be different. The patient's concern and family members' concerns may be different. The treating doctor's goals and the treating doctor's concerns may be different. So it is about bringing all concerned parties together and coming to a mutually acceptable uh, care plan. And so that is pretty much what Dr. Mary also said. And we understand that the treating doctors are usually very busy with multiple things on their plate, and that's why as a palliative physician we come in and kind of uh, grease the machinery, so to speak, smoothen down things, and bit of training and communication sure helps.
Thank you for the answer. There is Dr. Punita. She wants to say something.
Hi, just wanted to say that it all depends upon also depends upon the goals of the individual patient. So I can tell you that, I encountered a situation where I was dealing with a malignant bowel obstruction for somebody, and the individual had constant vomiting, and sometimes this was fecalant. And the individual's goal was to travel back, to their residential place. And with the kind of vomiting and the amount of vomiting that was going on, there is no way that this individual could have traveled. So after discussion with the patient as well as the consultants that were involved in the case, based on the goals of the patient, eventually a venting gastrostomy was performed so that, all the backlog that was accumulating, all that could be released through the venting gastrostomy, and this individual could travel and get back to the place where they wanted to be. So, alignment of the goals as well as input from the patient and family and the consultants all together helped us, formulate this plan.
We have a comment from Dr.
Well
Anne.
said. Agree. Well said. Totally agree.
We have a comment from Dr. Anne. She says, how many times are we having the conversation with the patient and how many times are we having the conversation with the family?
I'm not totally certain if I understand the question, Dr. Ann. Are you wondering about kind of family versus patients, or how many times we might address a given topic?
I just think often in India, we're talking to families and collusion might occur, as Dr. Koshi has commented. We might be having this conversation with families and not really truly understanding the goals of the patient. Mm-hmm. So if you could address collusion, Dr. Biju and Dr. Mary, that would be really helpful.
And I think it's probably appropriate, Dr. Biju, if you're comfortable taking this first, since you better understand the context within India.
Right. In India, the patient autonomy is always subservient to the family's wishes. And as a result, we have to make sure that the family is on board. And as often happens, that there is collusion and the patient is not in the loop. So when we are dealing with total care vis-a-vis end of life care, and this is the topic we are talking about, protecting the patient from force feeding, it is also important that side by side we also manage collusion. Collusion management is not just necessary to communicate bad news to the patient. It is also, as you correctly pointed out, to find out what are the goals of the patient and what are the concerns of the patient. Until and unless we get a chance to get deep into what the patient wants and what the patient thinks, until unless we don't get a chance to do that, we are never going to reach there. And collusion management is again a communication skill set that we all need to learn and practice to get better and better. Today perhaps is not the day or time for that. But if Dr. Mary would want to touch upon that, please, would be interested to hear your side.
And I think this is a challenge for me to weigh in on, because I come from such a different setting, right? And I've only really practiced in the United States, where we have such a strong individualist culture, right? And so oftentimes I address things by, feeling an obligation to at least explore with the patient what they want to know, how much they want to know, whether they prefer to defer things to their family or prefer to be the one making their own decisions. is oftentimes how I feel obligated to practice here. I do see, we have a question asking, at end of life, most patients become apathetic and would not like to communicate. How can we or their family know their choices or preferences? And I think that is one place where I might consider, assuming everybody's comfortable with it, exploring with the patient how much they want to talk about, right? And what they do want us to know directly from them. When it's really me speaking with the family members, I will often ask them kind of questions in general about their loved one. Just have, can you describe them to me, right? Can you tell me a bit more about them? What do they enjoy? What, how have they made decisions in the past? How have they felt about different steps in their medical care in the past? And I'll use those kind of guiding questions to help me get a bit of a picture about them, the way they make decisions, the things they value, depending on their stage and their trajectory, right? Are there specific activities or hobbies they might want to get back to, right? I had a patient recently where we were trying to decide whether we were going to do a relatively minor procedure, but it would have had a few weeks of recovery time and a prognosis that was maybe on the order of weeks or months. And the family said all she'd want to be able to do is watch TV and be with her grandkids, not at the hospital, right? All she likes to do is watch TV and watch her grandkids. And given our current visiting restrictions with COVID, the hospital was not the place to do that. So sometimes those little pieces of them can be really valuable. That was game-changing information, even though it was so tiny. Other thoughts you have on that, Dr. Bijou?
Yeah, I do come across a patient who may, I don't know whether it would be apathy or perhaps not interested to communicate, born out of multiple episodes of frustration and eventual resentment with the medical system, that they appear that they don't want to communicate. What I have seen that most of the time, when we are, as the medical team, when we go into the patient's room, we talk to the family about the patient rather than talking to the patient about the patient. And most of the time, the family responds on behalf of the patient. So patient is usually a mute witness to the interaction between the medical team and the family. However, if we were to make an effort to engage the patient, what I have seen that it is often the case that the patient are fairly responsive. And if we add our communication skills and empathy into the picture, I would say that the empathy can be probably taken care of. Maybe if the patient is fairly down the road, moribund, may not work. But by and large, people have learned not to communicate, and it's just a question of going in there and getting them out of the shell, so to speak.
Dr. Rajam has a comment in the chat box that in India, which is often the case, that families don't think it's wrong to keep the patient uninformed. So, like they want to care for the patient and protect the patient. This is their general idea behind doing this. So, what do we do about this thing in case of collusion?
That's exactly where our interaction with the family becomes important, because in this process we sometimes forget that as much as the patient is suffering, the family is suffering too. They are anxious, they are scared, they are sad, they are frustrated, they are depressed. They are going through almost all kinds of emotional trauma that perhaps the patient is going through, and sometimes even more. So it is very important to not be judgmental about the family. It's very important to acknowledge that the family is suffering. It's important to empathize with the family, and we have statements of empathy we can use, and most importantly, listen to what they have to say. And listening goes a long way, and that is one important way of gaining their trust. Another important tool to gain this trust is to use your symptom control knowledge to make sure that the patient is comfortable as much as possible. And then the family sees that you are making that effort to make their loved ones comfortable. They see your effort. And these all together helps in the family starting to trust you. And once they start to trust you, then they will listen to you. And that is the point of time where you can make them see the importance of managing collusion, the harm of the conspiracy of silence. Most of the time, you will see there's a turnaround in opinion and attitude. Sometimes it just doesn't happen. When you do whatever is possible from your end, it's like kind of fighting with one hand tied behind your back. But if that's what you have, you work with that.
Very well said, Dr. Biju. I agree with this completely. Also, we had one comment, how to deal with an angry relative. So I think that is the next presentation that we have.
Right.
And I
Uh,
think,
I think there are
and
some
I
more
think
chats
just,
coming. If we could quickly go through that, then maybe we can get on to the next part. I'm sorry, I interrupted Dr. Mary. You were saying something.
oh, no, and I was just trying to say, along the lines of what Dr. Bijou was saying, oftentimes when I have a family that really is nervous that if I say something, if they let me in the room, I'm going to say something devastating to their loved one, and it's going to make their condition worse. They're going to be more stressed. They're going to suddenly completely change. Because oftentimes just hearing I'm the palliative care specialist, I'll find that I meet families at the door. Like, you need to be careful what you say to my loved one. And oftentimes I will listen to those family members outside the room, or tell me what you're most concerned about. You know, tell me what your experience has been so far. And then I might say something kind of simple, like, you know, in my experience, oftentimes patients who are going through this have a sense that things are changing for them. Sometimes they have questions. And you know, would you be okay coming along with me if I tried exploring a little bit about what they already know is happening to their body? And I won't push things today if they're not, you know, seeming to want more information. Are you okay with me telling them things if they ask me questions? And so just asking, kind of aligning with the family before walking in the door, and potentially asking questions to patients. What do you think is going on? Because I've had some patients who don't really want to engage in that and just defer to the family. And I've had other patients look at me and say, am I dying? I think I'm dying. And it can really shift things for the family. When it comes to the patient themselves. But sorry, Dr. Bijou, you were thinking move on to our next presentation about more ICU level care. Is that what you were saying, suggesting we do next? I will share the other. So the next one, we were going to do more remap practice, kind of more in the context of discussions of end of life when you're trying to counsel a family about ICU level intervention. Is that my computer having the feedback of sound?
Yes, ma'am.
Oh, I will try to figure that out while Dr. Bijou gets us started.
All right. So I think we are keeping good time. So we come to the next part, that is protecting terminally ill patients from critical care. Again, now this is something that commonly comes up. Uh, so many of the times that the picture of ICU is like this. It's a very alien environment. And as I really like to say, this is where all your deliriums come true. And Dr. Mary was the first one who heard it from me, and you are the first audience to hear it from me. So there goes. So this is something, a very, very scary environment. And most of the time in our acute care setting, this is all that is there. You either have the general flow, wards and rooms, or you have critical care ICU. Next slide. So when we have a critically ill patient and a terminally ill patient in the same environment, which is the intensive care unit, what's the difference there? How are we differentiating how we are caring? Because they are two different entities. A critically ill person is not the same as terminally ill person. So why put these two totally different kind of patients in the same environment? It doesn't make sense. Next slide. And therefore, we need to understand what is critical care, who will benefit from it, and what is end of life care. To start off with, a critical care is what we see in the intensive care unit, where you have the intensivist or sometimes the anesthetist doing a certain role, and that role is to save a life. In the process of saving a life, we have to put a person through a lot of medical, physical torture. And it is justifiable because, hey, we are trying to save a life. In the process, the patient is in the ICU, family is outside, and they don't know what is happening. If the patient is unconscious, at least the patient is spared the misery, but at least the family is going through a lot of psychological distress. There's a lot of panic, there's a lot of frustration, there's a lot of anger, because they don't know what is going on. And on top of that, especially in the Indian context, a lot of financial distress is put upon the family. All of this is justifiable because we are trying to save a life. That is what critical care is for. That is what an ICU environment is for. However, next slide, if we have a patient who is known to have a disease which is now incurable or incurable at the time of diagnosis, it is progressive, and in the advanced stages, then you can't save the person's life. There is no life to be saved. However, we still need to protect that person from suffering. So when you subject a terminally ill patient to medical physical torture, now it is not justifiable. It is unethical. I would say even immoral. Subjecting the patient and the family to the same psychological distress while we were trying to save a life is unjustifiable in this situation where we cannot save somebody's life. And definitely pushing the family into poverty is absolutely not justifiable in a terminally ill person. Mind you, terminally ill person may not be actively dying. A terminally ill patient may be terminally ill for days, weeks, or months or more. But a terminally ill person is somebody who does not have a curable, a terminally ill person is somebody who has an incurable, progressive, advanced medical condition. It can be a malignancy, it can be an organ failure or multi-organ failure. So that is the essential difference. In one situation where somebody's life can potentially be saved, subjecting the person to physical, psychological, and financial distress is justifiable. Whereas in the other situation where somebody is terminally ill, none of this is justifiable. Therefore, there are two different kinds of patients, and treating these two different kinds of patients the same way is not evidence-based medical practice. Hence, next slide, we need to ask ourselves before we think about our patients and other random people, think about ourselves. Each one of you watching this right now, if you were terminally ill, how would you like to go? Would you like to spend your last days or weeks or even months in an ICU? Or would you like to spend your days, weeks, or months, if possible, at home, in your own bed, in your own room? Or if that is not possible, in a hospice care environment, where your physical comfort, peace of mind, and dignity of life will be taken care of. The choice is up to you. Maybe I don't know whether it is possible to take a random vote, but I would assume, I would hazard a guess that most of us would prefer not to be in the ICU if we are terminally ill. I can vote for myself, I can speak for myself. I wouldn't ever want to be subjected to critical care if I were terminally ill. I would rather somebody takes care of me physically, make me comfortable, give me some peace of mind, and maintain my dignity of life. Next slide. And this word, end of life care, next slide, does not have the word death in it. Because remember, as a palliative care practitioner, we have always known that end of life care is not about death. We are not focusing on death. We are focusing on life. And whatever little precious is left, there is plenty to do to make it comfortable, peaceful, and dignified. So comfort, peace, and dignity till the last breath of life. That is what end of life care is. It is not about death. We're not talking about peaceful death. We're not talking about painless death. That is euthanasia. Palliative care is pole opposite to the idea of euthanasia. Euthanasia people talk about death. They give you, they tell you, I'll give you a beautiful death. We are saying we will try to give you a comfortable, peaceful, and dignified life till the point of death. The focus is on life. Next slide. End of life care is all about, next slide, life. And I would like to stop there. And this is the kind of words I use when I'm counseling the family so that they understand that there is positivity involved. Next slide, please. Yeah. So now I'll hand the baton back to Dr. Mary. The stage is yours.
I'm hoping that this works better here. I may need to turn off my speaker while I'm speaking. Actually, it's working now, I think. Is this better? I hope.
Yes, ma'am. Yes, ma'am.
Great. So here we were going to walk through, hopefully we have time to use some multiple choice questions just to try to walk through what would this really look like if we have a patient coming in, we're trying to talk about whether or not to go to the ICU using this remap method. So we'll just give a very brief stem. So you have an 82-year-old man with metastatic pancreatic cancer admitted to the hospital in septic shock 1 week after he is deemed not to be a candidate for cancer-directed therapies. for the sake of this, we'll assume that at the time the family was told he was not going to get additional cancer-directed therapies, they were also understanding that this meant that he would die from the cancer, right? And so you're concerned that he is dying now, and you need to establish whether or not he will be transferred to the ICU. His adult children are his decision makers. He isn't able to engage in this discussion right now. So kind of using the method we talked about, we would ask the question, what do you already know about your father's condition? And you may hear from them that you know he's not a candidate for cancer treatment. I'm also going to say, as somebody who works in a hospital in a consultative role, the spot I'm often in is that the family member looks at me and says, the other doctor says he has an infection and probably needs to go to the ICU. And I'm sitting there thinking, ooh, I don't know that this is really considering his whole picture. So the first thing we want to do is we want to reframe. And Raju, how do we get this into the multiple choice question? I'm hoping people can give an option of what they think would be a good reframing question, how they might approach this based on our discussion. Go ahead.
Yes, so on the screen, you can see 4 options. You can click onto the one which you think is the most appropriate one.
Great. And I should say that not all of these kind of potential answers for the questions we ask are necessarily statements that would always be bad or statements that would always be wrong or always inappropriate. I'm just hoping that we can use these as examples if we were really going to be holding to this remap plan or method. And we intentionally use statements that might have some rationale behind them. It looks like things have slowed down here. So maybe we'll share results. So most people did choose option B, which is the kind of reframing statement that I would recommend. The reason being that it provides a sense of concern and empathy rather than any sense of abandonment or dismissal, right? That we may actually feel like, oh, that it doesn't seem like there'd be a point to sending him to the ICU. But when we kind of make that statement of pointlessness, that can really feel abandoning to the family or dismissive to the family, right? Same thing, a lot of times when we say things are futile, it can be really difficult for the family. So oftentimes we might frame things in terms more of like the risk and benefit. So I'm worried the ICU may not be the best option for him. I'm concerned your father is very ill and time is likely short. It is relatively direct, right? I might even use the words, I'm concerned he's dying, right? But it's giving that I'm worried that the ICU may not be the best option for him, kind of turns that whole picture around. He's dying, we need a different plan. I think the directness of being clear that you do think he is dying is important. It's just that keeping it open of depending on the patient and their values, our plan may be different. For some patients, the ICU may really be their plan. And then you need to give that space and expect emotion. So which of these might be an approach you might take to addressing emotion, right? So A, it sounds like you're feeling overwhelmed. B, you need to be calm so we can talk. C, oh, sorry for the typo. I understand things have changed much more quickly than you expected. Or D, what's going through your mind right now? I'd be interested in what kind of resonates with people. This is I'll be honest and say there's more than one that I would consider correct.
Dr. Mary, we have a problem here. This is not the questions I just uploaded. Sorry from our end.
Oh, sorry, what was that?
These are now the options I just uploaded in the polls. So we are not having this question right now for polls.
Oh, okay. So it's not going to work. We'll fly through it. Okay.
No, it's not going to work.
Okay. So I would say here, any of A, C, or D, I would consider really appropriate responses to the emotions that you might receive when you've just told them that you think their loved one's dying, right? That it'd be common for somebody to be overwhelmed, and you can simply name that, right? And we had a question in the last discussion that was about how do you address anger? If someone comes out and says, you know, is kind of yelling at you, you can say, I can see this seems really frustrating to you, right? And then I might actually add on something like D, an exploratory statement. Tell me more about what's on your mind, or like what's going through your mind right now. Tell me more about this. Tell me more about, you know, why you think that we made a mistake last time, right? Sometimes you'll get people who will make statements that indicate they're blaming other medical providers for the spot we're in, right? This wouldn't have happened if the oncologist had just given him chemo last week. Tell me more about that concern, right? And it's once we get to a spot of understanding really where this concern is coming from, that we can actually give them the information they need. Sometimes people will start telling you more about their anger, and not infrequently, I actually have people kind of then complete the circle on their own and say, I know that he's dying. It's just not fair, right? And I don't necessarily have to do much of anything. Sometimes it's a statement or two from me, just giving them the space to let it out, right? And to not blocking them out, not walking out the door. But as long as they're being safe in the room and not abusive of anyone in the room, I just hear it out. That would generally be my response to anger. And an understanding question statement can be as simple as, you know, I understand things have changed more quickly than you expected. And with any of these statements, I'm going to leave space. I'm going to see where they're going to go. I might use all three of these highlighted statements with one patient or one family member. The reason why I would not recommend D is I wouldn't recommend telling families how they should be behaving or feeling, right? They're feeling however they're feeling, and we need to just accept it unless there's a safety concern. And then the next step would be to map out goals and values, right? And so I'd like to see how people might approach this on this remap method. Option A would be, do you want me to make him comfortable or not? Or option B would be, should I try to restart his heart if it stops? That might be one of the more common ones I hear. Option C is, what do you want me to do? And option D is, if time really is short, what would be most important to him? So it looks like the majority of people chose D, which is what I would recommend, right? And the reason being, a lot of times we focus in medicine on what am I going to do next? I need to know what I'm going to do. And so oftentimes the way to kind of get there is to hear from them what's really going to be valuable. So trying to hear from them, well, he'd want to be comfortable. He'd want to be with family. Sometimes the answer I hear is whatever you need to do to keep his heart beating, right? And a lot of times that may come from a place of deep religious belief. So it's that, what is important to you as a family? You tell me, and then I'll put it into medical terms and into options. Oh. And then aligning with values. So based on what we've discussed, oh, the poll keeps popping back up for me. Oh, here we go. So if you're trying to then align with values, curious how people might approach it hearing this too. Options being A, what I'm hearing is that your top concern is your father's comfort. B, you should really be more focused on comfort. C, I think we need to be more realistic. Or D, he's too sick to reach those goals. Okay, so again, people are mostly taking A, which I tend to agree to, right? It's important that we do outline as we move forward what we think are realistic goals and what we think are potentially not, right? I saw some comments going through the chat box about the uncertainty we have. And I think that's important, an important reason why often when I'm reframing, I am using that wording that does leave that space, right? That isn't necessarily making firm determinations of what's right, but it's outlining that I'm worried or I wish that I saw this happening, right? Those are kind of my transition statements to open this door so we can explore. And based in that uncertainty and based in what's really most important is how I'm going to make my recommendations. So I like this A of just reflecting directly what they're expressing as their values, right? And it's not until that I can make the plan rather than telling them where I want them to be. This is what I'm hearing is most important. If what I'm hearing does not sound realistic or achievable, I'm still going to move forward where I'm going to make my plan next. I'm going to make sure that I'm couching my plan and the information I'm giving in terms of how realistic I think it is that we're going to reach those goals, right? So being reflective allows you to verify the accuracy of what you're hearing from them and allows you to demonstrate that you are hearing them. And maybe we can skip making this one a poll. So I had a couple of options, but I think I'm really going to highlight this one here, that when I'm outlining a plan, I'm going to make sure I'm framing it in the words they're giving me, right? Given how important comfort is to your father and family, I'd recommend we focus fully on making him comfortable for whatever time he has remaining, right? I'd recommend we avoid transferring him to the ICU because I'm concerned procedures there might cause him discomfort without fixing the underlying problem. I saw a comment in the chat box that asked about what if somebody's breathless and they are really concerned about that and thinking, shouldn't we put him on a ventilator because he's breathless? That's a question that I get a fair amount too, right? So once I've given my overarching recommendations, I'm going to pause, I'm going to listen to those questions, I'm going to feel those emotions that the patient or the family members have. And then I'm going to clarify, you know, I'm also concerned that he looks really short of breath. What I'd recommend is that we treat that shortness of breath, that we give him pain medication that won't change anything about his lungs, but it'll help his brain to not feel so short of breath so that he can relax. And that's when I would recommend, as I think someone else responded in the chat, that we give a low dose of morphine to try to help that breathlessness without putting someone through a procedure. And then always, after I feel like we've gotten through a plan, I'll ask something along the lines of, how are you feeling about this plan? Or acknowledge that was a lot of information and I want to make sure I communicated clearly. Can you summarize in your own words what our plan is going to be going forward? Making sure we're on the same page. And so by no means do you need to use this remap method, but we wanted to offer you one potential approach that might offer you kind of a framework of wording that you can use, and I find can be really valuable for transitioning patient and family understanding of a clinical situation for exploring those underlying values and goals that might impact the decision at hand and future decisions, to make sure you're aligning with the family and really developing kind of goal concordant treatment recommendations. And so I think, again, here we can open it up for more discussion. I haven't been able to keep track of all of the comments coming through the chat box. I think we have a lot we can talk about.
We have one question which is coming in like 2 or 3 different comments, which is basically how to manage anger. So one situation is the relative abusing, and it very commonly happens in India that the doctor, the other paramedical staff, they actually get beaten up. So how to manage this anger situations with angry relatives? How do you go about it with respect to the communication part?
And Dr. Bijou, hearing Raju say very often get beaten up, I worry that's a different scenario than I've encountered. So I may let you go first.
Right. I think I would divide this into 2 parts. One is clinical anger that we encounter in our clinical environment on a day-to-day basis. And then there is a law and order problem, which is due to mob violence or violence by one or more than one people under the influence of alcohol or other substances. As healthcare providers, we must all be trained in communication skills to deal with anger, how to diffuse anger in our clinical environment before it gets out of hand. And there are modules and sessions available for that. However, if we are dealing with a law and order problem, definitely not our area of not our area of expertise. We should leave it to law and order enforcement agencies, whether it be private with employed in the hospital or police or such a thing. So making that distinction of law and order problem, we are not the right people, but on a day-to-day basis, there are a lot of anger that comes about in our clinical experience. And please remember, anger is just a high energy consuming negative emotion that comes out of an underlying frustration, probably multi-etiology in nature. There could be many reasons that the person gets angry, and it just builds up and just just waiting to explode. And as healthcare providers, we all need to get trained. Now, having said that, again, this is not a module for that, but just a few things. We need to have a certain body language when we are dealing with it. For example, if somebody is getting very angry, there is so much of adrenaline in the angry person's body, that person just cannot sit down. The person is standing. And if you are sitting down, you as the healthcare provider is sitting down, as a healthcare professional, if you're sitting down, it creates a hierarchy, and that anger can increase. So it's very important that you also come into a standing position so that both the bodies are equal in position. The next thing to do is make sure that the posture is correct. It is courteous. A little bent of the spine forward shows that you are not aggressive, shows that you are not going to harm this person. So you are showing respect and courtesy. Respect by standing up, and courtesy by bending this a little bit of kyphosis in your spine. Not too much, just a little bit. And then the third thing to do is you make eye contact. This shows that you are confident, and it is not possible to get angry or an attempt to harm a person who appears to be confident. So these are 3 things that is basic when dealing with an angry person. And when this person is yelling and shouting, You may not be the reason for that, but you have, as an expert in communication, you have to come in the picture, make eye contact, stand, and with a little bit of kyphosis in your spine, you come in the picture, and then you start nodding your head. You start nodding your head in agreement with whatever this person is saying. You don't have to say a word. In this way, you are facilitating ventilation of emotion, and the high emotion comes down because you are neither confronting the person nor ignoring the person. You are respectfully, courteously, confidently interacting this person with your body language. And by nodding your head in agreement, you are allowing this ventilation of emotion. And once the high anger comes down, it doesn't go away, it just comes down. Then you can ask the person, or you can name the emotion, as Dr. Mary was saying. I see that this is very frustrating for you. And then next thing, I would like to know more about it. Can we sit somewhere and talk about this? So that is how, then that is the next step where you get this person down. And while sitting down, again, you do the same thing that you were doing when you were standing up. We just keep quiet, allow this person to ventilate. Now you're sitting down with your spine a little bit in kyphosis, eye contact, confident, nodding your head, and allowing this person to ventilate more and more. And probably this person will ventilate everything and come back to the previous situation that Dr. Mary was talking about. This is just not fair. That is one possibility. Or there's a possibility that you may have identified a real problem for which you have a solution. And if you have a solution for the person who is aggrieved, then you offer the solution and settle the matter. It is possible that this person is aggrieved and there is just no solution to that problem. And if it seems reasonable, offer a sincere apology. If it does not seem reasonable, don't apologize, because we don't want to be seen to be apologizing for the heck of it, because that again creates a bad vibe. So it is important to be honest about your apology. If it is indicated, do make an apology. If it is not indicated, just let it be. But the important question is, the crux of the matter is how you are going to safely allow this high energy negative emotion to be ventilated out without anybody getting hurt. That is the skill. I hope if Dr. Mary or anybody would like to add to it, uh, make a comment about it. I hope the answer helps.
This was very good explanation of how to handle anger, actually, Dr. Biju, and we encounter so many situations, but perhaps the way you said the talked about, probably that is the key. And also, as Dr. Rajam said in the comment box, that yes, communication is what is required, which probably the other consultants, since they are busy, we cannot blame them, obviously, but yes, because of some problems, this is missed out. And if we communicate well, yes, all these situations can be handled. uh, if there are not any more pressing questions, maybe we can hand over to Dr. Anne, who would talk about some questions regarding methadone.
Good evening. Sorry. Uh, just I wanted to finalize what will be our management goal regarding the case discussed, that a patient attendant says that okay, she or she has a cancer, but currently she is having an infection and which can be amenable to treatment, and she may resume her activity as usual. So, and probably if the infection is pulmonary and she is having malignancy somewhere else, so what about taking on mechanical ventilation for the initial distress, treating with antibiotics, and then see if it is curable or not. Thank you.
Yeah, I think that's an important question. And I was actually thinking of adding this caveat of what if the family says, no, our goal is time, right? I think every question we address, it's really important we're thinking about prognosis. I think it's important we're thinking about what's reversible, what's not reversible, and how they're interacting, right? So if I have a patient with lung cancer, metastatic lung cancer, no additional cancer-directed treatment options, who's getting a post-obstructive pneumonia, I'll talk through with the family about the fact that we could try treating this with antibiotics. We can hope that we'll buy more time and buy more quality time. And we may very soon wind up in the same spot again, because we're not fixing the underlying problem, that cancer that's blocking the airways. And so making sure we're on the same page about what we're choosing, right? And I might counsel them about there may come a time when it isn't about coming back to the hospital and getting more antibiotics. I would be concerned, about kind of the exact details of the scenario, whether we really thought that intubating someone would lead to us getting them extubated. I would want to make sure we were couching the discussion in terms of how likely we thought it was that we might actually get them back off of a ventilator, how likely it is that we think we might actually get them back home if that's their goal. If somebody says he wouldn't care if he ever got home, he would only want to know we did everything we possibly could to prolong his life, I will look to Dr. Bijou for context, but within my clinical settings, we would say, okay, then we will do everything we can to try to prolong his time until we can't anymore, right? And there are things that are beyond our control, and we're going to keep in contact about this. And if our goals ever shift, then we will shift plans, right? I might look to Dr. Bijou for other thoughts here.
Thank you, ma'am.
See, the idea of end of life care is not to deny patients things that would be beneficial to the patient. If an antibiotic therapy is likely to add to the quality of life of the patient, we may not be able to increase the quantity of life because of the underlying disease or the organ failure. But if an infection can be taken care of and that gives relief, by all means. End of life care does not mean denying everything to the patient. It means only protecting patient from futile medical intervention. So by all means, we should give antibiotics to the concerned patient, but we would not shift the person to ICU and subject him or her to CPR and intubation and ventilation. That is the only point to be made. By all means, we will give oxygen if required, we'll give antibiotics, we'll try to correct electrode imbalance if need be, if it is indicated. All of that things is to be done. Anything and everything which is beneficial to the patient, yes. Nothing to be done which is harmful to the patient, and anything futile is deemed harmful.
Thank you, sir.
Thank you so much, Dr. Bijou and Dr. Mary. Over to you, Dr. Anne.
Thank you, Dr. Mary and Dr. Bijou. Wonderful to see you both. I am wondering how people are doing with their methadone problem sets. We've received 5 of them from you. I encourage you to get these done while we can help you understand how to do the methadone while you're doing this course. So please, I know you have very little free time. If you would please do those problems and send them to Raju. She'll get them to us, and then we'll get an answer set back to you. So, and just encouraging everybody to get those done, pull out your calculators and get us your answer set. If there's any questions, don't hesitate to let us know. I see a new message, maybe. Thank you. You can send to tipsecho@palliumindia.org. Thank you, everybody, for continuing to advance your knowledge in palliative care. And thank you very much to our professors, Dr. Bijou and Dr. Mary, for making this happen. Well done.
I feel this was an excellent session, and what we learned today, especially the way Dr. Biju showed us a good way of making the concerned caregivers understand that force feeding is not an option, and so is critical care for a terminally ill. And we had a good discussion on how to handle collusion and anger, and knowing the remap method as a way to communicate in the most difficult situations is definitely this is the I think this is like what key of all the communication that we could possibly do in palliative care. So thank you so much, Dr. Mary. Thank you so much, Dr. Biju. And thank you so much, Dr. Anne, and everybody else. So thank you, and good evening to you. If you have any questions, please also mail them to